Hello and good evening to all our participants. We are very happy that you have made time to join us for this evening's webinar. We are very excited to talk about very important subject area for all who look after children. We're talking about respiratory disease in the setting of HIV for children. And we have great speakers with lots of experience speaking to us this evening. So we have two speakers. Our first speaker I would like to introduce is Associate Professor and works at Madrid in Spain. He has lots of experience in HIV lung disease. He has participated in lots of clinical trials, and he has 80 publications to his credits and has contributed to many chapters of books. We are privileged to have Professor Pablo Rojo speak to us on HIV, clinical presentation, and management for children. Thank you, Pablo, for making time to give us this presentation.
Thank you, Sandra. It's a real pleasure to be here. I work in infectious diseases, so I know a lot of pneumologists, but I'm focused more on the infection, okay? I work in Madrid, Spain, as you mentioned, and I think this talk could be for European practitioners, but also I work in Africa, and I think it also could be for Africa. As mentioned, I have worked as a clinician, as a researcher in sub-Saharan Africa, where HIV in pediatrics is a real problem. So I'm going to give 4 cases to give the conversation, okay? To give the main ideas that I think that a general practitioner has to be aware, and this means saving lives. This is a typical case, for example, in Mozambique, 4-month-old infant that comes to the emergency department with fever for 48 hours, difficulty breathing, with a respiratory rate of 75, and the saturation of oxygen 86%. And I think most of the clinicians that work here will recognize that this is a severe presentation. The child is hypoxic and has a severe difficulty breathing. You could manage this child with even without a chest X-ray, but if you have it available, you can see this bilateral pneumonia. And I want everybody to think what this could be. And it could be obviously a severe pneumonia, but caused by what? And I want to remember or remind you that the treatment of severe pneumonia in children in sub-Saharan Africa, based on the WHO guidelines, is either ampicillin plus gentamicin or ceftriaxone. And this is the first-line antibiotic regime. And bacterial pneumonia is quite common in children living with HIV and non-living with HIV. But this severe presentation has to think on something else. Something else is happening. And we see these children every day in sub-Saharan Africa, especially in countries with high prevalence of HIV, because this could be PCP, pneumocystis carinii pneumonia, or pneumocystis girovecii. That is why in an infant below 12 months, empiric cotrimoxazole treatment should be started, even if you don't know if this child is HIV or not, because this presentation with a chest X-ray requires acute empiric cotrimoxazole on all these children, okay? From 2 months to a year. And what else? You should ask for an HIV test in any child presenting with this. Because as I mentioned, you have to decide if you want to treat the pneumonia with antibiotics plus cotrimoxazole plus steroids for PCP, but you need to test for HIV because you might treat the acute infection, and if you don't test the HIV, the child might die later on because of low CD4 counts. So these are missed opportunities that cannot happen. This child could also present in Europe. We have had a couple of cases in the past 5 years of children presenting like this in my PICU, and one of them died because of the delay in diagnosis of HIV. So bear in mind, these children still present to the emergency department. Children treated with IV antibiotics and high dose of oral cotrimoxazole are still seen and have a very high mortality. Even with this treatment, have a 32% overall mortality, higher when they are younger than 2 years old, higher in malnourished children. So this is another point to take home. Malnourishment is associated to several things, but one of them is HIV and severe HIV. So we decided that this was a very high mortality, and we decided to study this in my study group, and we went into the different series on causes of death in children with autopsies, and this is a study in Zambia showing that several children, especially the children, had either bronchopneumonia or pneumocystis jirovecii, but also there were other bacteria like tuberculosis and viruses. So even 9% of the children had cytomegalovirus pneumonia. That is why we decided to go a bit more in depth, showing that the first cause of children living with HIV is PCP, as I mentioned, like the first case I presented. By the second cause, especially in the younger kids below 5 months, could be CMV pneumonitis, and also TB, it could be frequent. So we decided to run a trial, and this is an ongoing trial supported by EDCTP, run in 6 countries in sub-Saharan Africa, called Empirical. And it is the empirical use of valganciclovir and tuberculosis treatment in chest indrawing infants, in chest indrawing or severe pneumonia in HIV-infected infants. As I mentioned, this is an ongoing trial. We see this flow chart. We identify children below 1 year. We screen for HIV, and if they are HIV positive, they are randomized to one of those 4 arms. You can see the first one will be on the right, standard of care, so steroids plus cotrimoxazole and antibiotics. The second one will have valganciclovir. The third one will add tuberculosis treatment, and the fourth one will add both of them. This is an ongoing trial, so we don't know if this is of good, but we really think that CMV and TB might have some role in acute pneumonia in children living with HIV, because sometimes, and especially in HIV, there is the possibility of having more than one cause of the pneumonia. So we are about to finish recruitment in this trial, and we will let you know in the coming years if there is any benefit of this. Because we have to remember that the mortality in HIV-infected children had decreased significantly, but there is still over 100,000 deaths in children living with HIV. And the most common cause of mortality, and we are seeing this in sub-Saharan Africa, is still lung disease and most frequently severe pneumonia. I present the second case. This is a child which is a bit older, 6-year-old infant in Uganda, 6-year-old child, fever for 48 hours, no difficulty breathing, respiratory rate 25, saturation of oxygen 96. You can see there on the chest X-ray that there is lobar pneumonia. And when you evaluate the child, you take into consideration that the child has a moderate malnutrition, has been several times in the hospital, and the mother is complaining of severe diarrhea quite frequently. So again, my message is these children might be HIV negative, but if you see a child with 1 severe pneumonia plus moderate malnutrition, the child needs to be tested for HIV. And infants, you know that you need a PCR, but for a 6-year-old boy, is enough with an antibody test, an antibody rapid test. So for lower pneumonia, still to think on HIV, especially if malnutrition. Etiology is similar to non-HIV infected children, most common strep pneumoniae, but in HIV, you can see also Staph aureus or Haemophilus. And important, even in acute pneumonia, don't forget TB. Treatment, if severe disease, will be ampicillin plus gentamicin or ceftriaxone, and if good general condition, amoxicillin. In these children, if it is a lower pneumonia, it is very unlikely to be PCP, and especially if children are older than 2 years. Let's go for another case. This is a child, 9-year-old girl with 3 weeks of cough and mild fever, and no response to 3 antibiotic treatments. So any questions, anybody wants to write down in the Q&A any questions that you should do in these children? Anybody wants to write it down? What is the important question we have to ask to this family? Okay, I don't see any questions. I see several questions from the related to. Okay, so here is it: TB contact history, HIV status, TB contact, TB, any contact with TB. So obviously many of you are thinking of that, and yes, this is the question we always have to ask. Children always have somebody near them, or most of the time have somebody near them that have TB. But if we don't ask if somebody has chronic cough or has been diagnosed with TB, we might miss it. So agree, asking if the child lives with somebody with TB or somebody with chronic cough is essential, because different from adults that they might have TB because of a reappearance of an old infection, children usually is a primary infection. So it needs to be studied the family, or at least asked for. And this is the chest X-ray of the child. Any comments on the chat, in the Q&A? Looks like PTV, pediatric tuberculosis. That you can see that there is 2 main images. You can see that there is this image here that we can debate what it is exactly, but for our radiologists, it was an infiltrate with an increased ciliar lesion, probably a lymphadenopathy, and the second one is a cavitary lesion. So in this child, and in any child with persistent pneumonia or not getting better with antibiotics, or longer than 1 month, we have to think on TB. We agree on that. We agree that it's essential. And there is some comments: paratracheal strip with mediastinal lymphadenopathy. Exactly, that is what I showed. Some comments on iliac lymphadenopathy. Agree. So this is essential on a diagnosis. Never to miss opportunities like this. This child has been treated, as I mentioned, with 3 antibiotic treatments. Somebody has to stop and think, why is this child not getting better with 3 antibiotic treatments? Sometimes it's not easy to get a chest X-ray, depending on where we are. But even if you don't have a chest X-ray, you have a chronic cough for a month, you have an aunt with TB, you might even, depending on the setting, you might even think on starting an empiric. Okay, so thinking on TB is essential in a child with a chronic cough and several antibiotics. But the next thing is also to test for HIV. Somebody mentioned it. Any child, and this is essential in Spain, in Greece, or in Uganda, any child that has TB has to be tested for HIV. Depending on the countries, the prevalence is different. And there is several studies showing that in India, for example, where TB is very frequent, less than 4% of the children with TB will have HIV. But in sub-Saharan Africa, depending on the country, is between 20 and 35%. So any child with TB has to be tested for HIV. And this is the message. HIV is an important disease and TB as well, but both of them are related. If you have HIV, you will have to rule out TB. And if you have TB, you have to test for HIV. So this is essential. And that is why the WHO is working together, TB and HIV program. What is the treatment of a TB in child living with HIV? So very easy. Same TB treatment for HIV positive and HIV negative. Same drugs and same duration. Usually, the TB will need 2 months of daily rifampicin, isoniazid, pyrazinamide, and ethambutol, and 4 months daily of rifampicin and isoniazid. This is the most common WHO recommendation. Maybe some countries have a different recommendation, but it is the same drugs and same duration for HIV positive and HIV negative. Is there any news? Yes. So there is a fantastic new, recently published, that is the SHINE trial. The SHINE trial, led by Dai Gibb and published by her group with Anna Turkova in the New England Journal of Medicine, showed that shorter treatment for minimal TB in children could be treated with 4 months instead of 6 months. There were no inferiority in the children treated for 4 months than in 6 months, both in children living with HIV and non-living with HIV, with a smear negative, non-severe TB, both in Africa and India. And that this is something that some countries have started to do. Remember, non-severe TB is when there is a lobar infiltrate, there is not obviously a miliary disease, the child is not immunosuppressed, and is obviously only for lung TB, for TB in the lung, okay? So it will be the same regime as I'm showing here, 4 drugs for 2 months, and then 2 months more with 2 drugs, okay? And I think most of you know well, but there is a fantastic treatment by UNICEF, and most of the sub-Saharan Africa countries have the use of the child-friendly fixed-dose combination for the treatment of TB. And there is a combination of rifampicin, isoniazid, and pyrazinamide in 3 drugs plus ethambutol, and then the continuation phase will be with rifampicin, isoniazid. It is unlucky that in Europe, in Spain, for example, we have no availability of these drugs, and we have to combine with different pills still, okay? So what happens with the treatment of the HIV? So these children start treatment with TB, and somebody was asking, when can I start the treatment of HIV? We usually recommend, and this is WHO recommendation, to start the antiretrovirals within the 14 days. It's better not to start right away at the same time, but to start early, the better, within the 14 first days. Always starting with the TB treatment, and then the HIV treatment will follow. What is the treatment for the HIV? So there is a problem with rifampicin that interacts and lowers the level of several of the antiretrovirals that are or used to be first-line therapy in children, like lopinavir or nevirapine. And that has been a challenge for many years. Efavirenz could be given at a normal dose, but it can only be given to children living with HIV that are 3 years or older. So the problem is that lopinavir, ritonavir needs to increase the ritonavir part, which is called super boosting, but most of the countries do not have it available. And dolutegravir, which is a fantastic drug that has become first-line treatment all over the world for children living with HIV from 1 month and 3 kilos and above, any child above 4 weeks or a month and 3 kilos can receive. There was initial data that for children over 25 kilos, it could also be given dolutegravir, but only doubling the dose. This is correct, but not only for children over 25 kilos. we are doing this trial empirical that I presented, but now we know that even in children below a year, you can see in the graph the PK results for this group is very interesting because it gets very good levels of the drug when given twice daily in children receiving rifampicin. So secure to give dolutegravir, only that instead of giving it once daily, to give the same dose, but every 12 hours. And I want to finish with the last case. This is a child, 11-year-old boy living with HIV, now we know, non-adherent to antiretroviral treatment, non-productive cough for 2 months. Somebody started thinking on TB. The child did not get better after antibiotic treatment, but the child has general lymphadenopathy, and in the chest X-ray you can see bilateral reticulonodular infiltrates. So anybody wants to give a thought on the diagnosis? Obviously, it could be TB, and we have to rule out TB. In fact, this child started TB treatment, but it was not doing okay. And when the physical exam was taken, this sign could be seen. Anybody wants to comment on this child? What could this be? Somebody said PCP, sarcoidosis, ATB, atypical bacterial pneumonia. I don't know what that means exactly. Any other diagnosis? Well, the first thing to rule out is tuberculosis, pediatric tuberculosis. Sarcoidosis is not that frequent. Pneumocystis carini could be, and it has to be ruled out. But with this lymphadenopathy, with these fingers, there is another alternative. It could be miliary TB. In fact, the chest X-ray looked like a miliary TB, but didn't respond to TB treatment. There is not bronchiectasis, that could be, but the chest X-ray do not show that reticulonodular infiltrate. And the child did not respond to TB treatment. And the answer of this is lymphocytic interstitial pneumonia. I don't know if many of you have seen this. This used to be very frequent in the times when there were no antiretroviral treatment, especially in children, not so common in adults. And this is related to Epstein-Barr virus that gives kind of like a proliferation of lymphoid proliferation that occurs like this. There are different chest X-rays, different patterns. It is a chronic lung disease, frequent, as I mentioned, in children with no treatment and low CD4 counts, and it presents similar to TB with persistent cough and sometimes mild fever, but it has characteristically drumstick fingers, general lymphadenopathy, and very common bilateral chronic parotitis. There is no treatment for this specific, but it gets much better when they optimize their antiretroviral treatment. So the answer is lymphocytic interstitial pneumonia, and this child got very well when antiretroviral treatment was performed. Okay? So somebody said it as well, SHARS, lymphocytic interstitial pneumonia. Somebody mentioned LIP, which is the same. So thank you very much, because the audience knows very much. So with these 4 cases, I wanted to highlight the importance of thinking on HIV in any child with either severe pneumonia or a pneumonia that is not going well, to remind that always that you have TB, you have to rule out HIV. Thank you very much.
Thank you very much. This was a very clear, nice, and also interactive presentation. And so I'm really honored to introduce the second speaker, which is really an expert in the fields of HIV. It's Professor Rudzani Muloiwa. He was trained as a pediatrician in South Africa, did also part of his training in London, was very involved in HIV care as being the chief clinician and director of the pediatric and head of department of the pediatric and child health at UCT and at Red Cross. and currently he is the head of the pediatric department in Red Cross. His PhD centered around pertussis, and he's also very involved in vaccination, being at the moment the part of the National Immunization Technical Advisory Group in South Africa. So please, we're very curious for your talk.
Thank you very much, Marijke. Can you hear me?
Yes, we can hear you very clear. Thank you.
And you can see my slides, right?
Absolutely.
Okay. Thank you very much for this opportunity and for this chat. I have to confess, when I first tried to put this together, I thought it would be more or less straightforward. And then I realized I don't actually have a lot of time to cover in detail. And I thought I'll just stick with some principles. And if anything does come up on questions, we can talk about specific vaccination spaces. So some of you would know this, that for the majority of the existence of human beings on Earth, their life expectancy had barely touched 33 years. For most of our existence, we've been sitting below 30 years of age. But something dramatic happened not too long ago. In fact, if you move forward, you realize that we gained about 55 years over the last, 300 years or so, with about 2/3 of that years being gained over just the last 100 years. So it's really, really, really been phenomenal when you look at that, what has happened over this time. And a lot of this has had to do with what we managed to gain over infectious diseases. And a lot of these are actually respiratory illnesses because of just the large burden of deaths as a result of respiratory related diseases. There are others that are not respiratory, but a lot of these have actually been respiratory, as you'll see. So if you read what Stanley Plotkin says at the opening of this the edition of vaccines, is that in the history of the 20th century of public health, there's probably been no other intervention that has had such profound impact on health other than maybe the provision of clean water that would exceed the impact that vaccines have had in improving public health. The unfortunate part is that when you zoom very carefully, you realize that these benefits are not the same. So although you can see that Africa lags quite behind, and part of this lag is most likely related to lack of access to healthcare, other issues related to nutrition, but also one of the major impact that has actually made Africa was in a trajectory to improve health, and then we had that wobble in the 80s and 90s and early part of 2000 with HIV, and there is a bit of regaining of that recently, especially with the introduction of antiretroviral therapy. But there has been a major impact on that, which is negative. But one of the things that still impacts negatively to Africa has been the lack overall of access to preventive care, in particular, access to all vaccines that are available. So you realize that as I talk about these issues, I'll probably bring into the picture an issue that worries me and bothers me all the time, which is an issue of equity, not just for Africa, but within the African continent, for children that and even adults that are HIV infected, or as we say, people living with HIV and children living with HIV. What is really sad is that when you look very carefully here, you'll notice that the more poorer a region is, the higher the total, higher returns on vaccination is in the world. So in fact, the poorer you are, the more valuable and high the impact is of vaccination in that space. When you are from a poor area, when you get severe illness, there is no safety net. You basically just die. ironically, you'll notice as we go that the poor areas are the ones that get less vaccines. And as you look very carefully, you'll notice here that this is measles, Haemophilus influenza, and strep pneumo. As the areas for these more poor area, Africa, as well as Southeast Asia, and even Western Pacific, that the large bulk of those are what is related to respiratory, having made the largest impact of up to 80, or even here in Southeast Asia up to close to 90% with respect of that saving. So vaccines have made a big difference, and the largest impact of that has been in respiratory related disease. As science developed, you'll notice that as we move from using vaccinia as a naturally found vaccine to starting to understand the use of antitoxins and attenuation of pathogens and so forth, to the omics era, which is here, the number of vaccines being produced has skyrocketed as we went. In fact, when you look today, these are some of the pathogens for which effective and safe vaccines are actually available. Interestingly, more than 25% of these currently available vaccines are targeting pathogens that have got some impact on the respiratory system. A number of these vaccines are involve different ways of making them, including different targets, different designs, as well as what these vaccines are intended to achieve. So, I mean, you know very well with like SARS-CoV-2 that we've had those that we've got inactivated, we've got adenovector, we've got messenger RNA based vaccines and so forth. And for others like pneumococcal, you may have a conjugate, or you may have the ones that are polysaccharide and so forth. Pertussis, you may have whole cell, you may have acellular vaccines. All these have got implications in terms of responses to immunity from someone who is HIV infected, as well as what the safety profiles of those vaccines will be for specific ones. Like, for example, measles, which is a live attenuated vaccine. So now coming back to HIV infected children, why is this important, and in particular with respect to respiratory disease? Well, since time immemorial, people have always known that young infants of women who had suffered from a serious previous infection, be it measles or or varicella or something of the sort, that those children were less likely to get ill when they're young. And part of this has been this issue where you get maternal antibodies, and the higher your maternal antibodies, the narrower this window of vulnerability before the child develop their own personal immunity comes in there, where they're protected by the mother. In fact, the higher this level is, the narrower that window is, and the less these antibodies are, the wider this window of vulnerability becomes. So children born to HIV positive mothers are at a distinct disadvantage as a result of impaired maternal immunity, and we all know this. And this is irrespective of whether those children are actually themselves infected or they're just exposed. They just don't inherit sufficient antibodies from their mothers to protect them. We've always known that this increased susceptibility that we see is there for quite the large proportion of their first year of life. And there are other understandings that this may be due to immune aberrations in HIV-exposed infants that result from, let's say, in utero exposure to HIV virion particles, or sometimes maternal antiretroviral therapy. But over and above that, we've always known too that there seems to be a slight difference in how they respond to vaccines. And I'll give you an example soon. So there's that. If you look at the work, for example, done by Chrissy Jones somewhere here in South Africa, you'll notice this situation where when you look at children that are HIV unexposed and those that are HIV exposed, you do see that for Haemophilus influenza, for pneumococci, for example, their levels of titers, of antibody titers, are much lower than of the children whose mothers are HIV negative. So there have been all these issues that we have known all this time. Another study that follows that, you'll be able to see that, for example, when you're even looking at the HIV-exposed infants and HIV-exposed infants with respect to the IgG in Haemophilus influenza B, pertussis, pneumococcal, and I'm just highlighting those because those are respiratory pathogens. You can see that the titers that are there may somehow become different with subsequent vaccination and subsequent immunization later on. But at the beginning, you can see that they've HIV-exposed infants have got lower titers as opposed to ones whose mothers were negative. So there is something quite significant and serious, and that again speaks to those respiratory-related, respiratory pathogens-related vaccines. Some of these can be overcome somehow when you start vaccinating them, that there may be some degree of recovery. And the more vaccines you can get in, you start seeing good responses when they're there. And you can see that for some of them, having fewer vaccine doses may not be as good as getting higher doses in terms of that. And that may be to do with the prime boost. And so that becomes, again, a very important principle in terms of making sure that vaccination is actually given and the appropriate number of doses are actually received with these children. But what we also got to understand is that this impairment is not just with antibodies, it's also with some impairment in cellular immunity. Again, it's very, very difficult at times to actually know what the real understanding and reason behind this is. And that becomes important with infections such as the ones that are viral, where you need good T-cell responses in order to be able to clear the virus if you should actually get infected in the first place. As the authors here concluded, that exposure significantly diminished measurable cytokine polyfunctionality in response to BCG, another pathogen that related to respiratory, even Bordetella pertussis. So there are all these kind of things that are related to this. When we did a study here in Cape Town, for example, with respect to pertussis, we realized that after adjusting for all other things, including age and number of vaccine doses, that the children that were exposed, even though they're uninfected, had about 3.5 times risk of getting pertussis, and the ones that were infected, in fact, could go as high as 4 times the point estimate risk of getting pertussis. We did a systematic review about 3 years ago, and what you could see was that the risk of pertussis in all these studies showed cumulative risk, even in children that are HIV exposed, uninfected, but in the same time, even the ones that were infected could go as to 1.5 times the risk on point estimate with respect to if they are infected. And this is in spite of them actually having been immunized and having had the same number of doses as other children. And that may be related to how they respond. So that is the first part to just remember, that they carry that respiratory risk in spite of immunization, but immunization becomes quite key in these children. The next thing that I think that is a major issue when it comes to immunization in these kids is the issue of safety as well as efficacy of these vaccines. How many doses do you need? How safe are they? And I think what I mentioned earlier on in terms of the design of the vaccines that they receive becomes a major consideration and a major issue of concern. And the first part of that is that live vaccines, one has to be quite careful with them. Important as they are, the trade-offs need to be considered with respect to these, whether it's measles vaccination, whether it's BCG. We have, however, as you very well know, with the establishment of good antiretroviral programs in childhood, realized that the issue of disseminated BCG disease, for example, is less likely in children that have been started on highly active antiretroviral therapy early. I mean, we used to see a lot of this in South Africa, I can't remember seeing many of these cases over the last 5 to 10 years. In fact, I've not seen any. And part of it is that the children that we are seeing have been started much earlier on antiretrovirals. So part of these risks that we used to see of being afraid and withholding vaccines in this group may have been related to the fact that these children were starting antiretrovirals a lot later, by which time they had lost a lot of their ability to control intracellular organisms, including mycobacterial infections. And that risk has been in many ways attenuated as a risk of early antiretrovirals. But I think what is important is to realize, which is the major issue I want to emphasize here, is that when it comes to a number of vaccines, the benefit for children to protect them against severe respiratory illness is much higher in HIV. So these are children that this is the work done in South Africa here before the introduction of vaccines. You can see what the cases per 100,000 is of invasive pneumococcal disease. These are children who are uninfected. And although the pattern looks pretty similar with HIV-infected children here, you'll notice that this is 35-fold higher, the risk that you're getting with these children. And you can see that when we had in South Africa to introduce the conjugate pneumococcal vaccine into the public space, we had to factor in HIV-infected children specifically because of that higher risk. And one of the reasons is that we know that our vaccine coverage and the cost of the vaccine was quite high, but it had to be specifically motivated for, because we were going to probably introduce a 2+0 schedule because we could afford the 2 doses. But we realized that if you don't get another dose at the end of the first year of life, you will then, the children that are HIV positive will carry that huge risk into the second year of life. In fact, once we started introducing the vaccine, the impact of the vaccine in the children that are positive. I think one of my slides fell off. Is this. You can see that for these children that are HIV positive, the same impact was there. In fact, what was really impressive is the realization that for these children, the impact was much higher. The risk of the impact on invasive pneumococcal disease was 18 times higher, the impact on of the vaccine. But for pneumonia, which is a major concern here for this for you guys, because we're talking respiratory disease here, was about almost 40 times, was 38 times. When you look at the impact of the vaccine, you can see this coming from those higher levels and coming down very low. Whereas although the pattern looks the same with those that are uninfected, they are coming from a much lower base. So the impact of the conjugate pneumococcal vaccine was much greater in this group. Why do I mention any and all of this? It's because as I conclude and I show you the things that we need to consider as we're going forward, is that usually a vaccine decision framework worries about the burden of disease, and that burden of disease needs to be population specific, and HIV-infected children and exposed may have a different burden of disease, and it will need the vaccine to be effective even in that group that you're targeting. And we need to probably speak and plan specifically for them. And I say this as I conclude because of where we are finding ourselves right now. When we look at RSV, for example, a large proportion of those that die, 97%, are actually in this low and middle income country area. And this is a passion of mine to worry about issue about vaccine equity. We're celebrating about 2-3 days ago with announcements that the FDA, in fact, is approved, the committee has approved, and we are hoping that in August there will be the FDA will finally approve the RSV protection in infants. It's the reason I started with talking about maternal initially, because what you do to the mothers and to get their antibodies higher is what then ultimately protects the children. The problem would come if we don't get access to these vaccines for these children. As I mentioned, what we know about even RSV is that the burden of disease in children that have got HIV, their rate of admission is much higher because of these respiratory pathogens. And this is a study that comes from the US. And this actually is looking even more in HIV exposed, uninfected infants. So one needs to worry about this. Why is that even more important for this continent? Well, it's because if you look back, you'll realize that with the use of antiretroviral therapy, two things have happened. More women who were not managing to have children because of HIV-related fertility impact are now becoming mothers because they are healthy, but they are still HIV infected and their children are HIV exposed. And our PMTCT programs have worked so well that for a number of countries, the PMTCT prevalence is like less than 1% of the antenatal mothers. When we did a study here in Cape Town, when we were just looking at pneumonia, about 25% of our children coming to hospital with pneumonia were actually HIV exposed. So they're becoming a larger and larger proportion, and we need to kind of think about them much more than even HIV infected children, because their spikes are going up in adolescence, but it's much lower in childhood now with that. So it's just a thought that I want to take back, and to remember that this issue of vaccine equity becomes important. Again, the poorer you are, and specifically that the impact is much higher in those with the highest risk, and including HIV exposed and HIV infected. Thank you very much. Let me stop here, and we can talk about specific vaccines if you need to do that, but I realize I would never have had time to talk about any and all of those. Thank you very much, Marijke.
Thank you so much. We would move straight to the Q&A session. So Prof, yes, you have given us so much education on the importance of vaccines as far as HIV in childhood is concerned. So there are two questions here. Should we follow the latest guideline in January 2022 of ACIP CDC for pneumococcal vaccination for HIV positive children?
So the issue here, which is also so important, again, I can just go one step back. The guidelines for HIV infected children, and let me, I don't know how to frame this. One of the most important things in terms of vaccination and immunization is to realize that the responses have to be local and contextual. So let me give you an example of the South African context. Our immunization schedule for pneumococcal is not the same as the American one. And from the outset, it factored in the country-specific implications. Obviously, and I think the ACIP aims for the ideal, but one of the most expensive standalone vaccines that we have right now is conjugate pneumococcal vaccines, at least within the African continent. There are other much more expensive vaccines that you have. So the question is, you may very well say yes, if you're basically working where you've got control of what you can to aim for the greatest ideal, including what combinations you use with it, including whether you prime with conjugate pneumococcal and continue with polysaccharide. But for us in children, we have found that the use of the conjugate pneumococcal with the current schedule that we have was justifiable, taking the cost benefit ratio of the regime that we have to use, which uses much fewer doses within that schedule. I don't know if there's any if the person was asking about any specific part of that advisory. Oh, you are muted. And welcome back, Pablo. Pablo has said if there are questions, he's also back for that. You're
Sorry, muted, yes, I'm back if there is any questions for me as well.
Shall we just take the last two for, or maybe one more for Prof Rudzani, and Marijke can help us with your questions, Pablo. Should that be okay? Okay, so Prof Rudzani, your second question is, how frequently do you recommend pneumococcal vaccine? I'm sure the person is speaking in terms of HIV infected or HIV exposed children.
So the first part is that the children that are HIV positive or HIV exposed should have all the standard doses as any other HIV unexposed, uninfected child. So that is the first part, is that our recommendation is for them to be on the same regimen. The only question that comes up later is whether in the specific context of a child, for example, that may have been delayed in getting antiretroviral therapy and they are quite immune depleted, and they now immune reconstitute. It's a question of whether you should consider giving them another dose. And that even becomes more important when they go into adolescent life, because whenever you think about children, for us, you always think about pediatric and adolescent. And in those cases, there may be a place for considering whether you should give them another booster dose later on within adolescence, which other recommendations have made. Others have given them that, almost like the way you recommend with the elderly, and sometimes follow up at that stage because they may be able to respond to even polysaccharide as a follow-up dose with respect to that. But as a general principle, I would vaccinate them just like I would otherwise other children that are HIV negative.
Okay, so there is a third question, but I will not read that. I want Marijke to help us attempt some of Prof. Pablo's questions. Prof. Rudzani, would you want to chat? Would you want to put an answer for the third and fourth questions, please? So Pablo can also respond to some of his questions. Marijke, over from me. Thank you.
Yeah, thanks for the two excellent speakers. I really enjoyed it. Concerning the questions for Professor Pablo Rojo, I think some of them have already disappeared from the chat, and my short-term memory is not working that well always, but maybe I can ask a question myself, and I'm very humble because my background, I don't have any experience in low resource countries. So I was wondering, when you have a child with suspected HIV with a severe pneumonia and the different etiologies you suggested, what diagnostic tests would you advise and what diagnostic tests are available? Because, for example, in our setting, we always say that PCP, for example, PCR should be performed on a lower airway sampling rather than upper airway sampling. CMV, you can test with PCR on upper airway, but I'm not sure if it's available widely in low resource countries. So could you give us advice if you work in, for example, Uganda, other countries you mentioned, what diagnostics are possible and what diagnostics you would advise so that we can more give directed therapy?
Thank you. So I think, depending on the setting, but most of the sub-Saharan African countries, except South Africa, do not have easily available CMV viral load, because there is a technique for it. So we are doing in our study, we are doing PCR for for CMV, and we are training some of the sites for it. But the truth is that we don't know yet what is the importance of CMV. So we are doing trials to know if there is a benefit. So if we show any benefit in the empirical trial that treatment with Valgan cyclovir is of benefit, obviously we will have to think on two possible possibilities. One is testing, or the other one is going like we do with PCP in some settings in which you go empirical treatment because of the lack of easy diagnosis also for PCP and treating them specifically HIV infected and a certain age. We know that PCP is below 1 year, probably CMV is below 6 months. Over.
Thank you. In the meantime, I see that there is another question for you. It's also in the continuum of diagnostics. Did you do a high resolution CT for the patient with lip, and did you see lung cysts?
Well, you see different things. Mostly it is not cysts. Most of them are really lymphoreticular nodal infiltrates, or sometimes enlarged ilear as well, lymphoid tissue. So it's quite difficult to distinguish sometimes from TB as well on a CT scan.
Okay. Sandra, do you have any questions from your part that we can answer for the next minute or so?
Prof Rudzani, so I think we can attempt your third question. I see you typing, but maybe just so that our participants can hear. So I'll read it out.
Let me give up, because I was trying to type very furiously.
Okay. Okay.
So I think it's a very fair point. The question is whether the studies in HIV exposed babies disaggregate into suppressed viremia versus unsuppressed during mother's pregnancy. There is so a lot of the children prior to maternal antiretrovirals who just had a higher chance of being born infected. I mean, we saw a lot of them in our settings. You're looking at about 40% of them having that. And that would also have had consequence of having much lower maternal protective antibodies because of polyclonal gammopathy with poor coverage of functional antibodies that are crossing the placenta. So it is a fair point. I was about to kind of just point out to a systematic review, for example, done by a group in Joburg, for example, just looking at measles and vaccination in HIV exposed. I was need to put that into the box, where you can see a slight difference with respect to that as children move into the new era where the mothers actually had antiretrovirals, and they may have had some degree of immune reconstitution, because that will change the baseline of the maternal antibodies. That will then give a bit more protection. But relative to HIV unexposed, they still are at a higher risk. And one of the reasons is that our immunoglobulins are not only about vaccines, it's about pathogens that we don't even know that the mother would have had enough protection against those ones. So the answer is it probably does span the whole spectrum, but there's probably much better protection with those whose mothers are on antiretrovirals.
Great, thank you so much, Prof. Do we have a minute to just answer the very last one I can see? Mariel, she says, thanks for wonderful presentation. Can you comment on maternal vaccination for pertussis, influenza, SARS-CoV-2? Is this feasible and affordable in parts of Africa if HIV is well controlled in the mothers?
I can give an answer for South Africa, and we are trying to do something in terms of growing awareness in the African continent. So it's become, for pertussis and influenza, the impact are huge for basically protecting infants and the mother with those two vaccines. Pregnant women are at higher risk of both influenza and SARS-CoV-2. And so the answer would be yes, it is feasible for pertussis and probably SARS-CoV-2 because of the support with COVAX and so forth. In fact, the issue now in a number of African countries, including South Africa, are people just not taking up the vaccines that are available. That's one. Pertussis has been an issue, and the issue has been the cost of our cellular pertussis vaccine, because you need to use Tdap, and that has been an issue. South Africa will be introducing it hopefully soon, but they had to cut costs somewhere else to find the money to change from tetanus and pregnancy. So we know it's feasible in terms of the program, because tetanus vaccination has worked very well. So the issue will be to replace tetanus with Tdap. The question is what the cost of that dose would be. And influenza has been a major issue because we just don't have sufficient doses, in part because there's not enough doses produced all over the world for that. So that's where the trick lies. And that is the reason why I was talking about inequity.
Marijke, over to you.
Thank you. I think we are coming to the end of this wonderful session. We had two excellent speakers with so much experience in the field, in research. It was really a pleasure to attend this, and from our part of the world, making me feel very humble. So I think this was again, a very successful cooperation between ERS and PATS. It's always a pleasure to work with the colleagues, the people of PATS. So I hope we will have many more of these nice webinars that are well attended. So thank to the organizers, the people from PATS and ERS and the speakers, and of course also the very active audience. Unfortunately, not real life, but online. So thank you all, and I wish you all a pleasant evening or a pleasant rest of the day.
Thank you very much.